All right, this is going to be OB and neonatal care. So, as you can see, this has 191 slides. This is going to be the bulk of your exam. Okay, this is going to be the bulk of your exam because the other sections that I'm aware of were special needs patients and the combat veteran. So, going through this, it has a breakdown of the female reproductive anatomy. All right, this is all important, but we're going to really isolate some of the areas that are most important, and we're going to talk about those in more detail. All right, so here, these are some causes of abdominal pain, or that can cause bleeding. We're talking about vaginal bleeding here. All right, so sexual assault, and on that, let's kind of take a caveat. If you were a EMT or a paramedic on a truck, don't ever use the term rape, especially right aside that survivor. You can use alternate language. Okay, you can say they're not a victim, they're a survivor. Okay, you can also talk about a SANE. That is a sexual assault nurse examiner. So a lot of people talk about a rape kit. It's actually a SANE kit, a sexual assault nurse examiner's kit, and that's what they use at the ER to fully document everything and to obtain samples from the patient, so that should they choose to go forward with prosecuting the perpetrator, they have that ability to do so. That's just a little caveat. Dysmenorrhea. Okay, so you should know this term. All right, dysmenorrhea is pain during the menstrual cycle. All right, pain during the menstrual cycle. It also has a German word that you might see on your national registry called Mittelsmutsch. Okay, Mittelsmutsch, and I'll try to find that and put it up here if you don't see it through the lectures. All right, ovarian cysts. Okay, so like we're talking about PCOS, polycystic ovarian syndrome, where we have cysts on our ovaries. Endometritis and endometriosis, two different things. Endometritis being inflammation of the endometrial tissue. Okay, the endometrial tissue is the tissue that lines the uterus. Okay, so you have an inflammation of the tissue that lines the uterus. And endometriosis, which is different from endometritis. Endometriosis is endometrial tissue outside of the uterus. And there are documented cases of it growing in the nose or even the lung. So the endometrial tissue can really appear just about anywhere in the body. PID, or pelvic inflammatory disease. We're going to talk more about that as we go through in the lecture, but this is most often caused by sexually transmitted diseases, which is the last topic here. All right, so we're talking about gynecologic conditions, sexual assault. So you're going to follow your protocols for reporting, whether that's a requirement in some states. Some states have mandatory reporters where they have to notify law enforcement. So we'll just follow your protocol for your department or your state. So these are some side effects, or these are the results of a sexual assault. So it could be very traumatic for the patient, not only physically but emotionally as well. They could receive genital erectile swelling because if they were assaulted, that may be it's against their will. Okay, so they're probably not prepared for this. It's not a consensual act. All right, you have bleeding pain. STDs are a possibility if the perpetrator is a carrier. And then that person, if they're male, could impregnate the victim. So there's always the possibility of a female perpetrator, a female on male, or female on female, or male on male. All these possibilities exist. All right, so we talked about some traumatic effects, whether it's a physical or psychological. Well, we also have the psychological aspect from these individuals. A lot of them suffer from PTSD, which are a lot of which this is kind of a breakdown of that. Flashbacks, nightmares, withdrawal, anxiety, depression. Those are all aspects of post-traumatic stress disorder. So it says you cannot force your patient to do anything or not to do anything, but you need to strongly recommend that they don't change, bathe, comb, or clean any part of the body, because that can remove evidence that can be found to persecute or prosecute the perpetrator. All right, and these are especially important for the SANE, that sexual assault nurse examiner, as they gather all that evidence. So cutting holes or tears in clothing, because that may be used as evidence if the perpetrator tore the victim's clothing. You're not going to want to do that yourself unless you have to tear or cut away to treat a wound. Okay, especially if it's a life-threatening injury, you're going to take those steps to treat the patient. Don't let evidence of the crime, don't let the destruction of evidence of the crime prevent you from treating the patient. That is going to be the most important aspect. Taking care of the patient first. As always, be non-judgmental, provide a safe environment for these individuals, and always respect them as a person. Okay, respect their privacy. Try to get them in the back of the truck as quickly as possible. That way, they are not around other people, and they can be more free to talk to you or your partner. Likewise, they may be unwilling to speak to you if you're a male EMS provider. They may want to speak to a female person. If the survivor is a woman, or the alternate, if the survivor is a man, they may only want to speak to a male EMS provider. So you may have to request additional resources. That is just getting another truck out for the gender that is appropriate for that call. All right, so there's also non-traumatic vaginal bleeding. This is just, it could be just related to their period or their menses, or they may have some other type of medical problem. The most common cause when we talk about medical problems is just spontaneous abortion. So the woman is pregnant, and the body rejects the fetus, and they have a spontaneous abortion. So some signs of this: lower abdominal or pelvic pain, tenderness, vaginal bleeding, rapid pulse, possible signs and symptoms of shock. Okay, they may be going to hypovolemic shock depending on the amount of bleeding that occurs. That menstrual pain, okay, we talked about dysmenorrhea, also known as Mitchell-Smirch. Okay, this is that strong uterine cramping that causes pain during menstruation, during the menstrual cycle, during their menses. All right, so ovarian cysts, we talked about this briefly, PCOS. So these are sacs that will surround the ovary, okay, and they can bleed, all right, causing vaginal bleeding, and they can flare up. They can be painful during intercourse or bowel movements where there's a lot of stress or straining on that part of the body. It talks about unilateral abdominal pelvic pain. That's if there's the cyst on one ovary. So it could be on both. So you could have bilateral abdominal pelvic pain, but there's a possibility of unilateral. That is just ovaries are only on one, cysts are only on one ovary. Endometritis, I broke this down earlier. This is an inflammation of the endometrium, okay, the tissue that is in the uterus itself. Okay, some signs and symptoms, basically the same thing. Distension, bleeding, abdominal pelvic pain or tenderness. Endometriosis, again, breaking this down. So for endometriosis, I'm going to expand on this a little further. There's 4 categories of this, and you need a surgeon to determine the severity of it, because they need a laparoscopic surgery to go in and actually visualize how bad the endometriosis is. So stage 1 to 4, 4 being the most severe. So you might have individuals that, especially during their menstrual cycle, have they may have bloody stools during the menstrual cycle, because that endometrial tissue may have started growing inside of the rectum or around the rectum. So that's a possibility that they may complain. When I say complaint, we're talking about chief complaint. We're not actually talking about someone just griping. They may complain of rectal bleeding during that time frame. PID, pelvic inflammatory disease. This is an infection of the female reproductive tract, the entirety of the tract. Okay, so this is most often caused by STDs. And one of the most kind of uncommon symptoms that you see here is anorexia. Okay, just due to the amount of pain that they are in due to the PID, they don't eat. All right, so we're talking about the entirety of the tract. So starting at the vagina, the cervix, the uterus, going through the all the way up to the ovary and including the fallopian tube. So that bacteria enters through the vaginal canal and just starts to work its way up through the entirety of the woman's reproductive tract, and it causes pain, or can cause pain, to the entirety of that site. STDs. So there's 4 different categories here. Bacterial, we're going to break those down a little bit. You know, when we talk about bacterial, we're talking about chlamydia or gonorrhea. You have viral STDs like herpes, okay, is one. You have parasitic, and you also have fungi. All right, so like I said before, gonorrhea and chlamydia, these are 2 different types of bacteria. Also syphilis, these can all be treated with antibiotics because they're bacterial in nature. And then you have your viral HIV, herpes, or genital warts. And then you have your parasitic STDs. Probably the most common one of the parasitic are trichomoniasis. STDs, now this is not a catch-all because you may have some of these signs, none of these signs, and sometimes STDs go without any signs or symptoms, but they can cause fertility problems in both men and women. Always, get your BSI on, depending on what's going on, and especially if there's a possibility of impending birth, and we're going to talk about that in a little bit. All right, so when we're dealing with these patients, okay, so they may be in severe pain, so pain medication is not really going to be an option so much as an EMT, but we're worried about shock, especially if they have like signs of a severe spontaneous abortion and they go into hypovolemic shock. So be prepared to treat that. As always, provide modesty and patient privacy, be compassionate, and always, above all else, be professional. All right, so just kind of moving on from here. These are just some signs and symptoms you may see, some generalized questions that you should ask. So if if there's trauma involved, let's say it was an assault, HABCs, just go from there. HABCs and treat the patient. Like I said, evidence is important, but treating the patient is more important. All right, so we're talking about childbirth and what we as EMTs may have to do for out-of-hospital deliveries. And we're going to talk about some complications that we may see in the field and differentiating between those two. Okay, this is, you may or may not see this on the test, probably not. We're talking about the sections of the uterus. Okay, the layers, like I talked about, the endometrium, myometrium, and perimetrium. Okay, endometrium is probably the one you're probably most familiar with, if you're familiar with it at all. All right, we know what the placenta is. Okay, that's what's going to provide all the nourishment and waste removal for the fetus. Okay, the umbilical cord is what attaches the fetus to the placenta. The amniotic sac is what surrounds the entirety of the fetus. All right, so talking about menstrual cycle. Okay, it's typically a 28-day cycle. All right, during menstruation, the endometrium is shed. All right, so like I was talking about earlier, someone with endometriosis, that they have endometrial tissue outside of the vaginal, or excuse me, outside of the uterus, during their cycle, it's going to shed and bleed and be very painful for them. All right, this just talks about the breakdown of what exactly is happening during gestation. Okay, so the first 14 days, it's a fertilized ovum in the pre-amniotic phase. Then we go to the embryonic phase, and then moving on to the fetal, so on and so forth. Okay, so the woman is gonna develop a mucus plug, and that's one of the things that that separates when they're about to give birth. Okay, when we talk about the bloody show, and when their water breaks. Okay, and we'll talk all about that later. This just talks about some of the physiological changes in women. There's an increased demand for oxygen because now they're breathing for two. There's an increased demand for nutrients because they're eating for two. And the cardiac output increases because they are now, like I said, breathing for two, but the baby obviously isn't breathing, so all that is done via the placenta. All right, so some other physiological changes. They may complain of heartburn. Okay, so that's a very common complaint in pregnant women. Constant urination is another one. So frequency increases, especially as the child gets larger, because now it's pressing down on the bladder. So the glomerular filtration rate, what is that? That's called your GFR, glomerular filtration rate. That is the number that is assigned to your kidneys on how well they are filtering out toxins of the body. So because the amount of blood in the woman increases during pregnancy, so does the need for the kidneys to filter everything out. Like it says, renal blood flow. Renal, we're talking about the kidney system. The renal system, we're talking about the kidneys. Okay, so the GFR also increases because we now have more blood to filter out. Some unfortunate aspects here is that the pelvic joints loosen, okay, and actually all joints loosen a little bit, okay, and this is so it's easier for the child to pass through the birth canal. I talked about this in a previous lecture, hyperemesis gravidarum. Hyper meaning accelerated or higher emesis, vomiting, gravidarum, pregnancy. Okay, so they are vomiting more and more often while pregnant. This is typically just called morning sickness. Okay, so we're talking about this this condition. So nausea, vomiting, okay, excessive salivation, headaches, syncope, or jaundice. Why are these things occurring? So they may be vomiting so much that they are becoming hypovolemic. Okay, just like any other episode of hypovolemia, you're going to have to treat your patient because they can easily go into shock. So ideally, you would want them to drink water, but if they are vomiting that up as well, you're just going to have them go no PO, that is nothing by mouth, and you're just going to have to get them to the hospital or an ALS intercept so they can provide IV therapy. All right, so for this, care is supportive, like I was saying, just monitor their ABCs. One concern that can escalate is that if they are actively vomiting, all right, and they go unconscious due to being hypovolemic and they continue to vomit, we're worried about them aspirating. All right, so that's just something that we have to take into consideration. Okay, so these are some things that you're guaranteed to see on your exam, and we're going to talk about them more in depth as we get to them. When we talk about placenta previa, abruptio placenta, abruptio of the uterine lining, and what an ectopic pregnancy is and why that is a life threat. Okay, I'm talking about spontaneous abortion. We briefly discussed this earlier. That's a delivery of the fetus before 20 weeks. Before 20 weeks. You might see this on a test question about what is the definition of a spontaneous abortion. It is the delivery of the fetus and placenta before 20 weeks. Okay, so what do you see here? A lot of abdominal pain and cramping, similar to labor. All right, and they start to pass large clots. Okay, very large clots. An ectopic pregnancy. This is a medical emergency. What an ectopic pregnancy is it's a fertilized ovum, so the egg has been fertilized and implanted anywhere outside of the uterus. It can happen anywhere in the female reproductive system outside of the uterus. In the next slide, we're going to go into photos where that could be, but it is most commonly found in the fallopian tubes. Okay, so it may be the patient may be experiencing pain unilaterally, okay, because the fallopian tubes are one on each side on the, like the right or left upper quadrants of the abdomen. So here are some places, and when it talks about the likelihood, it talks about the percentage of where it may implant, okay? It can plant inside the cervix, outside of the uterus, in the upper abdomen, inside the ovary itself, or like we said, most commonly in the fallopian tubes. And what can happen is that it can rupture, causing a rupture of the fallopian tube, and now we have internal hemorrhaging, and we have a medical emergency. So it's incredibly painful. This requires surgery, and we need to get the patient to the hospital as quickly as possible. So how do we manage it? We're going to talk about that after we talk about some of these signs and symptoms. They may have referred pain in the shoulder. That is, they may have pain in their abdomen on that side that may also radiate, or they may have referred pain in the corresponding shoulder. That decreased blood pressure would be especially dangerous here if they become hypotensive due to hemorrhaging. All right, so we're worried about the patient hemorrhaging, and we're afraid of that decreased blood pressure. Okay, so placenta previa. So for testing purposes and for the real world, knowing the difference between these two is important. Because one is a pretty immediate life-threatening injury, and the other is a massive complication, but more so for the infant than the mother. Okay, one affects both, and the placenta previa is more dangerous for the child because the child cannot escape, it cannot get out. Okay, so this is where you have an abnormal implantation of the placenta that's near or over the opening of the cervix. Okay, so as the child tries to descend, it can't because it is stuck. Okay, in placenta previa, and so you can differentiate for your exam. The pain here, so they're going to have bleeding, but non-painful bleeding. Non-painful when we're talking about placenta previa. Okay? Non-painful bleeding for placenta previa. I'm trying to look for that, but I don't see it here. But for abruptial placenta, this is where the placenta has torn away from the wall. Okay? It is torn away from the wall. This is going to result in the fetus immediately starting to suffer because the placenta is no longer doing its job. Okay, you may have severe bleeding causing hypovolemic shock in the mother, so the uterus is going to bleed. The placenta itself may be bleeding as well. With abruptial placenta, it says the bleeding may be minimal, but you can still have severe hemorrhage and that severe hypovolemic shock. So in abruptial placenta, they're going to complain of severe pain. Okay, placenta previa, minimal to no pain. All right, but blood is typically present in both. Okay, placenta previa, severe bleeding, minimal pain. Abruptial placenta, minimal bleeding. Did I say that backwards? Placenta previa, minimal pain, massive bleeding. Abruptial placenta, massive pain, minimal bleeding. All right, so what do we have to do for these patients? Get them on O2, okay, and then just drive fast, okay, start treating for shock. Ruptured uterus, so a tear in the uterine lining. So you may have an infant that has torn through the uterine lining. Okay, this is going to cause pretty severe bleeding as well, and the patient can also go into shock due to it. All right, seizures. Okay, so these are more questions that you're more likely to see on your exam and your national registry when we talk about seizures. Okay, when we talk about preeclampsia and eclampsia. So preeclampsia is a systolic blood pressure greater than 140 over 90 millimeters of mercury, so greater than 140 over 90 on 2 or more occasions, 6 hours apart. So let's say they come in one day, they are 160 over 98, okay? They come in 2 days later, they are 158 over 94, okay? They are considered preeclamptic. They are in preeclampsia. So they are at great risk for having a seizure. So this is typically when women are put on bed rest. This is typically when they're put on bed rest because they are afraid of that patient starting to have seizures. All right, so preeclampsia occurs most frequently in the last trimester, most likely to affect women in their 20s who are pregnant for the first time. Preeclampsia is a more severe form. Eclampsia is a more severe form of eclampsia, and it includes coma or seizures. So preeclampsia becomes eclampsia when they start having seizures due to the elevated blood pressure. So they may have a history of hypertension. They may have already be hypertensive. They may have some type of organ disease, diabetic kidney, liver, or even heart. They typically have not had any previous pregnancies. And the sudden weight gain, okay, puts a lot of stress on their body, which can cause that elevated blood pressure, that hypertension. They may be altered. They may have blurred vision. They may have a severe headache. These are all signs of hypertension. All right. Swelling of the face, fingers, legs. All right. So again, hypertensive patients, they may have swelling in their extremities. Supine hypotensive syndrome. So this typically occurs in the third trimester. All right, because the child, the fetus, okay, is crushing the inferior vena cava. Okay, so that's why pregnant women, especially as they are further along in their pregnancy, are not recommended to lie on their back. Because as we see here in this photo, we'll go back to the last slide in a second, if they're lying supine, that is directly on their back, the child is compressing the superior vena cava. So they have basically all the signs and symptoms of shock, cool, clammy skin, tachycardia, so an elevated heart rate, and lower blood pressure, decreased blood pressure. All right, so pre-delivery emergencies. How do we treat this? You're going to elevate the patient, okay, so that they are on, or the weight is off of that inferior vena cava, so rolling them onto their left side. Rolling the patient onto their left side at approximately 15 degrees. So placing a blanket, a towel, or multiple towels or several pillows, okay, under them, so that we can elevate them off, or elevate the child off of that inferior vena cava. If that's not a possibility, okay, let's say they've been involved in a motor vehicle accident and you have to place them on a long spine board due to cervical involvement or any type of spinal compromise. Obviously, we now have another complication. We may have to manually displace the fundus or the uterus, okay? And we can do that with 1 or 2 hands. All right, so any female between 12 and 50 could be potentially pregnant. It could be an OB emergency. That's why in the sample history, L is not just last oral intake. We talk about last menstrual cycle. Okay, and it says any female between 12 and 50. As we all know, that that women or girls, I should say, are younger and younger, having their first menstrual cycles. Okay, so it's never a bad question to ask, if you can get the patient alone, if they've ever had, if they have had their first menstrual cycle. Because if they have, then they could possibly be, in this category. All right, so this is all common stuff. We've seen this a million times. Some other questions to ask. Have they ever been pregnant before? How many pregnancies? So when we talk about gravida and para, okay, we need to be able to differentiate that, because you're going to see on your national registry, they're not going to say they've had 4 pregnancies. They're just going to say gravida 4. Okay, gravida 4, para 3. That is that they've been pregnant 4 times. They've had 3 live births, and that maybe that 4th time they are currently pregnant. Okay, so they are currently pregnant, gravida 4, para 3. Just think if they are now parents, and that's why they are para. Or if you cannot remember that, if you can remember hyperemesis gravidarum, okay? So gravidarum, we're talking about during pregnancy, that morning sickness or that hyperemesis, excessive vomiting while pregnant, gravidarum. If they have been pregnant before, have there been any previous complications? And when was your last known normal menstrual period? So, here's a good question to ask as well. Let's say that they have had a previous cesarean section. They need to have another C-section in order to get that baby out. Just due to the risks involved with a natural birth, the risks after having a C-section, having a natural birth, go way, way, way up. And if you are in the if you are in a situation where they may be imminently going into labor, or they are in labor, knowing whether or not they've had a C-section before could adjust how quickly you need to get to the hospital. Or if they're in labor, you need to get to the hospital quickly regardless. All right, so pre-delivery, some other things we may see here: abdominal pain, vaginal bleeding, weakness, altered mental status, seizures. We talked about that earlier. They're eclamptic. Hypertension. If the patient is 20 weeks or more, avoid positioning them supine. We just talked about this. We may have to place them on their left side. All right. If we have to perform CPR, performing CPR on the mother may also save the child. Okay, because we have to keep both patients alive, or ideally we want to keep both patients alive. You're probably going to see this on the test when it talks about the division of labor. Okay, the different stages that it's in: dilation, expulsion, and placental delivery. That is, first stage being when the cervix dilates. Okay, so when the cervix starts to dilate, we are now in stage 1. All right, and then it breaks down that further. An important note here is Braxton Hicks contractions. So these are called false labor pains. These are called false labor pains. Braxton Hicks contractions mimic labor, but they are not true labor. We're still talking about that stage 1, the dilation of the cervix. Okay, as it goes from 1 centimeter all the way up to 10 to allow delivery up to the child. All right, still talking about contractions, and then we get to the second stage. This is actually the delivery, the expulsion phase or stage, is when the infant has passed through the vaginal canal, passed through the vagina, and they have been born. You may see the peritoneum bulging. Okay, if you do that, see that, that's impending birth. It's a sign there. Crowning, obviously, impending birth. We can see the patient's head. All right, and as the child is born, they are going to rotate. they're going to rotate. So you have to be aware of that. And it may be difficult getting their shoulders out. If they are caught in any way, all right, then you need to immediately evacuate them to a hospital. All right, so it says routine suctioning is not recommended. All right, however, if they do have meconium fluid, all right, which is stool that the infant, while in utero, has defecated, they may have meconium fluid, and that is just dark tarry stool. It may be on their face or anything like that. You may want to consider suctioning. Okay, you would suction their mouth first because you're going to take that first breath from their mouth, and then you would suction nose. So mouth, then nose. All right, support the head as the patient is delivered. Support each shoulder. They're going to rotate as they come out, and then gradually, or depending on how many births they've had previously, the child may be very quickly coming out of the vaginal canal. So if it's their first time, it's probably going to be a much slower process, and you're going to be able to actually kind of not pull them out, but you're going to support them as they are being pushed out. All right. Keep the infant at or above the level of the vagina until the umbilical cord is cut. Why do we have to do that? Okay, that's the same reason that when you are, let's say you just got done with a really difficult run or a jog, you want to keep your head above your heart, okay, so that you don't pass out. Likewise, we want to ensure that the infant can still get the nutrients that the umbilical cord is sending out, okay, that is providing the child. So, the third stage with the placenta being delivered, so I don't know if it talks about it. Okay, but let's talk about it real quick. When do we cut the cord? Okay, we don't cut the cord until the placenta has stopped pulsating. So once the placenta has stopped pulsating, clamp, cut. Okay, other times that we will cut the placenta before the placenta has stopped pulsating is if there's a nuchal cord, and we're going to get to that later. But if there's a nuchal cord, that is, if the placenta is wrapped tightly around the patient's neck, the child's neck, and you are unable to remove it, you're going to have to cut, clamp. Oh wait, clamp, cut. My bad. All right, the third stage, when the placenta is delivered. So typically this is 5 to 20 minutes after delivery of the child. Okay, never pull on the umbilical cord, just allow it to happen naturally. They're going to go through the exact same functions that they were doing before. They're going to bear it down to deliver the placenta. Keep the placenta with you for transport because it's probably going to get, what's the term? I can't even think of it anymore. It's going to go to histology. Pathology? Yeah. So I mean, it's gonna get examined at the hospital. So bring the. Say again. Yeah. So transport the placenta with you if maybe they had a home birth. Okay, take it with. This is just talking about gestational landmarks. Okay, about where or how old the baby may be based on the fundus. This is just estimating the child again. All right. Wrong slides. Pre-hospital delivery. Okay, if there is no suitable transportation, weather is inclement and you're unable to drive through it. All right, and there we just had imminent delivery. We have signs of crowning or the bulging like we talked about earlier. The patient may have a strong urge to defecate. They feel like they have to go to the bathroom, and FYI, the patient likely will go to the bathroom during their pregnancy, or during the delivery, excuse me. So make sure that you have something down under the patient to catch all that. If the abdomen is very hard and rigid, okay, that's another sign of imminent delivery that we have here. You should have OB kits on your truck, all right? So just make sure that you have the OB kit ready and available. Make sure they have all the standard precautions on. This is one that you're probably going to want a gown if you have it, gloves, And a mask isn't a bad idea either, because the patient, they might vomit. There's probably going to be stool. There's probably going to be urine. You're also going to have to deal with a little bit of blood. You also have there's a possibility of the amniotic sac rupturing, or water breaking, and that going everywhere as well. Here's an example of an OB kit. All right, so if the child is visible, so crowning is visible, and you can still see the amniotic sac is around them, gently tear it. Gently tear it, okay? And then as soon as the head has passed, the first thing you're going to do is assess for a nuchal cord. The second that the baby's head passes, assess for the nuchal cord. And if necessary, you're going to slip a finger under that cord, and you're going to try to slip it off the child's neck. If you can't, clamp, cut. Okay, here's just some visual examples. Okay, nuchal cord, we just talked about this. This is a double nuchal in this photo. We have the umbilical cord wrapped around twice, making it a double nuchal. So 90% of the time, it's going to be very easy to slip it off. It's not that big a deal, but sometimes it's wrapped around very tightly. And if that is the case, clamp, cut. You're going to want to dry the newborn off rapidly, okay? Because newborns are very susceptible to hypothermia. Newborns are very susceptible to hypothermia, so keep them dry, okay, and warm. And then you're going to do your APGAR score that first and 5 minutes. And I haven't reviewed this, but I'm pretty sure it talks about the APGAR score as well. Okay, we're going to talk about that because you're probably going to see that on your exam as well. Okay, so here it talks about where we cut the umbilical cord. Okay, so 6 to 9 inches from the infant, we're going to place our first clamp. 2 to 3 inches away from that, the second clamp, and then we're going to cut in between. And it doesn't say it on here, okay, but you're going to wait until all of the pulsating from the umbilical cord has stopped. That's when you cut the cord, unless it's an emergency like a nuchal cord or a double nuchal that you cannot remove. All right, so some other considerations. You now have 2 patients. You got to keep that newborn warm, and you also have to worry about postpartum hemorrhaging from the mother. So there's also the possibility that she bleeds excessively, and you may have to treat for shock. This would be a great time to have ALS en route, all right, to link up with you, because there's medications that paramedics can give, i.e. TXA, okay, which is a medication that is used to stop internal hemorrhaging. It was meant for this exact case. That is, women that are bleeding out after delivery. All right, childbirth, and we just talked about this. We're going to assess for the nuchal cord. Okay, the child is going to rotate. All right. Keep the baby level with the mother, okay, or above, never below the mother. Keep the baby dry and warm. 6 to 9 inches from the infant, clamp. 2 to 3 inches away from that, clamp. Cut in between after the umbilical cord has fully stopped pulsating. Allow for delivery of the placenta. Never pull on it. Never pull on it. Just allow normal delivery. So this baby, what's going on with this baby? They have... Yeah, we have a lot of central cyanosis. Okay, so not only is the baby's face blue, but the entire body is blue. We have a lot of central cyanosis going on here, so the SpO2 level is probably very, very low. Another consideration, I don't know if it's in here, but just something to think about. This may not be an EMT skill because we're talking about neonates, okay, less than 1 month old, but you may have infants that are hypoglycemic the second they come out. So they may show signs of, so the APGAR score may be very, very low. They may have that central cyanosis, pale, cool, clammy. They may be hypoglycemic. Again, don't quote me on this. Okay, so if you get it wrong in your exams, that's on you. Follow your protocols in your books, but you check their glucose level by pricking their foot. Okay, and you know how to do that. Yeah. So, well, you're taught that in phlebotomy school. Well, I was taught that when I went through phlebotomy school. That's all you need to. That's all you need to get to check their glucose. Okay, you only need a drop to check their glucose, and that's really literally all it takes. So if you have a baby like this, yeah, that central cyanosis. Okay, so we need to provide SpO2. So some resuscitation may be required here for these patients. Transport, obviously, administering oxygen not only to the mother but to the child. Okay. Um, we got to take care of these patients, okay, when we have mommy baby issues. All right, so if we have an abnormal delivery, okay, so maybe we have a prolapsed cord or a breech birth, we're going to tell her not to push. Do not push, okay? Place the patient in a knee chest position. That is, you're going to literally have her try to touch her knees to her shoulders, okay? This may allow for the child to deliver if it's imminent. She may not have a choice. You're going to tell her not to push, but the baby may be coming whether you like it or not. If that is the case with a prolapsed cord, okay, you're going to stick a gloved hand inside the vagina only to lift the baby's head off of that prolapsed cord, because that cord is the only thing that is providing that baby nutrients and oxygen. If the baby's head is compressing that cord, the baby's not getting any of that. All right, so breech birth. So this is the lower extremities are presenting, okay? We have a breech birth. So think of, I know this is corny, but breeches, or you might hear them called breeches, depending on what part of the country you're in or how far south you are. Okay, so a breech birth, the buttocks or lower extremities are presenting from the patient. Okay, do not attempt to deliver a breech birth in the field. All right, so you are not going to be able to. Okay, you need to get them to the hospital. They need to be seen by L&D immediately. All right, if the pre-hospital bleach is unavoidable, okay, contact medical direction immediately. Have the mother push hard during these contractions. As the infant delivers, support the legs. Allow the legs and buttocks to deliver until the umbilicus is seen. Okay, but you're going to have, it's going to be such a struggle here. And you may have more complications, i.e. vaginal tearing and hemorrhaging associated with it. You do not want to deal with this. All right, so these are 3 types of breech presentation. All right, so we have the frank, all right, the complete, and then incomplete, where we have just one leg sticking out. Frank is where one leg is up, okay, and that type of delivery is near impossible. They're probably going to need a C-section. All right, begin high flow oxygen, emergent transport. That is. And here's another thing, when we talk about rapid transport on your exams, especially in National Registry, this is off topic, but important here. When we're talking about rapid transport, they're talking about lights and sirens, okay? So when we're talking about emergent transport, lights and sirens. This is the Marceau maneuver. Is it described any more about this? No, that's all we get. So the Marceau maneuver is where you have to place your hand under and above the patient, trying to get their head out because they are in a breech birth. They're delivering feet or buttocks first. Okay, so sometimes you have these presentations where delivery is impossible. All right, so for example, that frank breech positioning is probably going to be impossible for the mother. There's also another type of, it's not a breech birth, but this is just limb presentation, okay, where you have an arm or a leg presenting. Shoulder dystocia. Okay, so the fetal shoulders are larger than the fetal head. So the head delivers, but the retracts because the is unable to get past the vaginal canal because the hips, okay, are not wide enough, and the shoulders, or I shouldn't say that. I'm not blaming the mother. I'm just saying that the physically the hips are not far enough apart to allow birth of the child due to the child's shoulders. Okay, like it says here, some difficulties here: entrapment of the cord, severe brain damage or death if the child is not delivered. So rapid transportation, licensed sirens is going to be very, very crucial here. In that shoulder dystocia, okay, placing the patient in the McRoberts position. Okay, and we're going to talk about that more in just a second. Okay, if the McRoberts position and suprapubic pressure do not allow delivery of the patient, you may be instructed to perform the gasket maneuver. So that I'm going to have to look up in a second. Okay, so again, the McRoberts maneuver is very similar to what we were talking about before, placing the or trying to get her to place her knees to her chest. Okay. Gasket maneuver as moves her hands and knees so the gravity can help release the baby's posterior. What is it you said? Oh, on hands and knees. Oh, is it sit here? Oh, okay. Is it next? Okay. All right. So the gasket maneuver being on the patient's hands and knees. So this is where we're talking about the suprapubic pressure, that is applying pressure on or outside of the vagina. Okay. So this is going to require more than one person because, as you can see here, nobody has 3 hands. The McRoberts maneuver, all right, so trying to touch those knees to the shoulder, and you're right, the gasket maneuver, so they're on all fours. Precipitous deliveries, baby delivered within 3 hours of the onset of delivery. These are fast deliveries, okay? This is most common in multiparas, that is, they have been pregnant multiple times, and they've given birth multiple times. There may be multiple births if there are twins involved. So the more children or the more neonates inside of the parent, of the mother, the more likely that each child is going to be very small in comparison to a single birth. We talked about meconium fluid earlier. Okay, so fetal distress can lead to fetus passing bowel movement while in utero. Okay, so they may have that meconium staining on their face, and they may aspirate that meconium. So you want to suction that. If you see it on their face and you just can't wipe it away, or if you see it in the mouth, you're going to suction the mouth, then nose. All right, so if meconium is present but the newborn has a good cry or vigorous activity, do not suction. All right, but if the baby is depressed or non-vigorous and the heart rate is less than 100 or is inadequate respiration, quickly suction the nose and mouth and bulb syringe and immediately begin positive pressure ventilations with a infant BVM. All right, so preterm labor. So preemies, this is what we hear because there's drugs or even medications that can cause preterm labor. This is anything that occurs between the 20th and 37th week of gestation. Preterm births, infant weighing less than 5 pounds or born before the 37th week of gestation. These patients are even more so prone to hypothermia because they're even smaller. Okay, so making sure that they are warm and dry, swaddling them immediately is going to be very important. All right, so this is what a full term should look like. Okay, and then a preterm. You can see the noted difference in size. So post-term, this child has been in confinement for longer than they should. This may necessitate a C-section, depending on how large the child has gotten. So you may have premature rupture of membranes. All right, so the spontaneous rupture of the amniotic sac prior to onset of true labor. So there are water breaks. This can lead to a risk of an infection. All right. When we talked about complications postpartum, so they have given birth, so some things can happen here: postpartum hemorrhage, a loss of greater than 500 mLs. So a non-pregnant woman, we think of 4 to 5 liters of blood. Okay, so this would be approximately 1/10 of her amount of blood. Okay, no, not 1/10. 5 liters. No, it would be. Yeah. Okay. So maybe my math's off. Doesn't matter. The point is, even if they are not pregnant or pregnant, 500 mLs is a lot of blood when it comes to anybody, and especially women, because they typically have less blood in their bodies compared to men. You may have embolisms, okay, so clots that form. You may have amniotic fluid embolism. They may present with shortness of breath, syncope, tachycardia, all these things that we see in just classic signs of air embolisms. All right, caring of the newborn. I've said this multiple times. They're prone to hypothermia. Swallow them immediately, suction if necessary. All right, and then we're going to perform an APGAR score. Okay, so that first and 5-minute mark. Appearance, pulse, grimace activity, and respirations. So when we talk about appearance, we're talking about, are they appropriate for their race, or are they bluish a little bit, or did they have that central cyanosis going on? Pulse, and I'm pretty sure it breaks it down later on, maybe not. Yeah. So when we talk about activity, these newborns, they're going to kick their legs. Okay, if they are a 2, they should be kicking their legs. They should be crying. They should be yelling. Okay, when we talk about the respirations and all that, we should have a loud cry out of these babies. When we get down into 0 to 3, all right, we're talking about life-threatening emergency here, providing CPR for these patients. 4 to 6, they may just have to be stimulated or kept warm. They may just require blow-by oxygen to get their SpO2 up. All right, if they're not breathing adequately, stimulate by rubbing or flicking the backs of their soles or rubbing the back. All right, still talking about care of the newborn. Talking about SpO2 levels to newborns. This is what we're talking about when we're stimulating the baby, rubbing the back, flicking the soles of the feet. If necessary, when we're talking about performing resuscitation, keeping the baby warm, positioning the airway, suctioning if necessary, stimulating the child. All right, this is we're just kind of repeating ourselves over and over again. Blow-by oxygen is one possibility for the infant, and then just case studies. All right, that's going to conclude this lecture.